Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for this next session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. You may also use the chat for communicating during the session. Please remember that no personally identifiable information is allowed when discussing cases. We are recording these sessions, and in the spirit of all teach, all learn, we'll be on a first name basis during the session. Our echo sessions always begin with a brief lecture followed by a case discussion. Cases include a question or challenge you want to address, and they're a critical component of the echo model. So we continue to encourage you to submit cases that can be related to patients, preparedness, policy, or whatever challenge you would like to generate discussion and ideas around. For today's session, Dr. Cynthia Chuang will discuss COVID-19 testing and primary care response, and then we'll revisit the case questions posed by Dr. Matthew Yu, Medical Director for Northside Christian Health Center. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State, and they will be helping field questions, and we'll also be looking to everyone because this is an all teach, all learn model. So we encourage everyone to share both questions and answers and whatever it is you are practicing in your area. And with that, I'm going to turn things over to Cynthia for our brief lecture.
Thank you, Jackie. Can you hear me? Wonderful. Thanks, everyone. I think we're going to get the slides up and going in just a minute here. And I will just say I'm going to talk briefly today about screening and testing for COVID-19 in primary care. I just want to say that what I'm going to talk about today is really specific to primary care. It's not intended to apply to the emergency department or hospitalized settings. Also, to provide a little orientation for those of you who are not nearby us, I'm here at the Penn State Hershey Medical Center in Hershey, Pennsylvania. We're kind of east central Pennsylvania. We're only a couple hours away from the hotspot in New York City. However, we're still only just seeing our very first cases right now. So that might give you a sense of kind of where we are. It's given us a little bit of luxury of a little bit of time to prepare ourselves on both the outpatient and inpatient sides. And I know there's an echo later today presented by one of my colleagues in hospital medicine about hospital medicine preparedness. So a little disclaimer, I'm a division chief of general internal medicine, and my goal here is to provide the best care I can for our patients while maintaining the health and safety of my providers and staff. I'm not an expert in infectious disease. I'm not an expert in disease preparedness. I'm just presenting today our experience in trying to implement the CDC guidelines into practice into our clinics. So what I'm showing you here, for those of you who are a little behind us in this pandemic, these are the areas that I've been spending a lot of time thinking about. For those of you who are ahead of us in this pandemic, I'm sure you have a list that's 10 times longer than this. But things that we've been thinking about is preparing your primary care team for COVID-19, screening and testing for COVID-19, which is what we'll be talking about today, maintaining a safe and COVID-19 free environment in your office, strategies for ramping down in-person encounters and ramping up phone visits and virtual visits, staffing plans, what to do when you have people on quarantine, and for those of you who may be providing backup care for hospitalists, having an exposure protocol, and then also how to monitor patients at home with COVID-19 who do not require hospitalization or who are post-hospitalization. So again, we'll focus today on the thing that's in red, screening and testing for COVID-19 in primary care. So this is the patient who you're trying to avoid walking in your door. We really want to really keep all respiratory symptoms outside of the office. So the two things we've done to really try to do this, and I feel like it's been actually very effective. I would say this week, there was only one patient who came in who we felt like we could have triaged out better. So really we've worked on elevating our phone triage protocols, putting more people on the phones as providers have cut back on their clinic visits, having providers be ready to help answer phone calls with people who are calling with their respiratory symptoms, and really kind of trying everything we can do to avoid people with mild respiratory symptoms to be evaluated by phone. The other thing we've done is greeting people outside of your doors before they come in. So the way we've done that is we've asked the screening questions that the CDC recommends, which is asking people if they have any fevers, any new shortness of breath, or any new cough. And if a person answers yes to any of those questions, we've asked them to return to their car. And then someone from the inside of the clinic is calling those patients to do an evaluation by phone. So with those measures, we've done a pretty good job of keeping this coughing patient outside of our clinic. So this is what we use to guide our history taking once we have the person on the phone. And for all the primary care providers on the phone, I'm sure these items are quite obvious and straightforward, but asking people if they have known exposure history to COVID-19, asking what the exact circumstances were related to the exposure and whether or not close contact occurred. Asking if they had any relevant travel history, so exact dates and cities of travel, including international and domestic travel, including airport layovers that have occurred in the past 3 weeks or so. Also asking about mode of travel, so did they travel by car, plane, public transportation, etc. And then symptoms, so the main ones are fever, shortness of breath, or cough, but certainly asking about other symptoms as well. Keeping in mind that fever is present on presentation between 80 to 95% of the time. Cough is usually dry and is probably present 50 to 85% of the time. Shortness of breath about a third of the time. There's also a lot of fatigue associated with this syndrome. And then there's a lot of less common symptoms that are probably not terribly helpful in your evaluation because they're very present in other conditions as well, like pharyngitis, headaches, and maybe even GI symptoms as well. And then kind of understanding if people are part of a special population. So if they're immunocompromised, if what their age is, if they live in a congregant setting, what their kind of occupational exposures may be, so on and so forth. Personal health risk profile, so what their own personal risk factors are, their comorbidities. Healthcare workers, as I already mentioned, and any other relevant information. So once you've gathered all that information, then you kind of need to figure out in your head what you think this person's risk is. So this is what we're using here at Penn State. Oops. Sorry, back one more, please. Thanks. So, oops, too far. Okay, this is what we're using here at Penn State. And so please see if you have any local advice from your local health system. But we have generally, and even before our institution came out with this guidance, in our clinic, we developed our own guidance. And it actually was very similar to this. We were categorizing people in 4 categories, as you see here, with level 1 being people who you really think have minimal or no risk. Level 2, and those level 1 people who are the people who are asymptomatic and really have no risk factors and just need some reassurance. Number 2 is people who are low risk. They have some respiratory symptoms. They don't have any risk factors. And that's where you kind of need to use your clinical judgment. And I'll talk a little bit more about that in a second. Level 3 is your moderate risk people. So they have some concerning symptoms, but they have some of those special, they're in one of those special populations that we just talked about before, where you have some concern about them. And then level 4 should be the no-brainers, right? Like they have concerning symptoms and they have high risk of exposure. So they had high concerning travel or high exposure risk, or they have confirmed close contact with a known COVID-19 person. So I think category 1 and category 4 are the easy ones in terms of what to do. And categories 2 and 3, those are the ones that are challenging. We have found in our group that when we have people's in category 2 or 3, until we get good at this, it's kind of good to just bounce these cases off of each other, because we find that we get confused about whether or not we should be recommending testing or not. But I would say it really depends on the prevalence of COVID-19 in your local community, right? So if you have very low prevalence or no prevalence right now in your local community, you might actually have a very high bar before you want to test someone, because there just is not a lot of community cases. But if you have high prevalence in your community right now, that might actually lower your bar to do testing, because it may be more likely. Another issue to consider, of course, is the availability of testing. And I'll talk a little bit more about that on the next slide, but whether testing is even available and whether you need to limit it to people who really are in the highest risk categories. So if you look at kind of the last column, I should say, of this chart, this is really going to be local guidance in terms of where you decide to send testing. So in Pennsylvania, we have the option of sending testing to a couple of different places, which I'll talk about in a subsequent slide. And I'll talk about how to figure out what that is in your local area. If you could help me get to the next slide, thank you. So I was talking a little bit about local prevalence and local availability of testing. So this is guidance that came out from our friends in the New York City Health Department, who have unfortunately had to put out this guidance suggesting no outpatient testing. And we know in New York City, the prevalence right now is unbelievably high, but their availability of testing and availability of PPE is just so low that they're not recommending any testing. So the people in that low risk category who you've decided not to test, I don't want to gloss over this too quickly, because these are folks that we have found are anxious, they're panicked, and they really need some good guidance. So we have found that it's been important to give people reassurance that they are in low risk and why you think that they are low risk. Recommend symptom management as you usually would for URIs, and also recommend that they continue to monitor themselves at home for fever or worsening of symptoms. It's prudent for them to stay home and avoid contact with other people, and then have some method for them to contact the office if their symptoms worsen or other questions arise. And of course, social distancing and hand washing until their symptoms resolve. One of the things I meant to talk about on the last slide, I'm sorry, I'll just talk about it here, because I know that there's going to be questions that come up about whether or not you should be doing other respiratory viral panel testing. And I think at least here in central Pennsylvania, we're still having very high rates of flu. So I think this is a very important question and deserves some consideration. So for the primary care providers on the call, you'll be very familiar with the respiratory viral panel that we often send to test for influenza, RSV, and other common respiratory viral pathogens. I also want to make a point that old-fashioned coronavirus is one of the viruses that's on that panel, and there is no co-reactivity of the old-fashioned coronavirus with SARS-CoV-2. So if we did have a couple of episodes where people were positive for coronavirus on the RVP, and it resulted in some alarm. So making sure that everyone understands that the coronavirus on the RVP does not cross-react with SARS-CoV-2. So if you do choose to do RVP testing, recognizing that there is a very low rate of co-infection, it's probably less than 2%. So if you have a low pre-test probability that someone has COVID and you get a positive RVP, you could probably pretty comfortably say that they are very unlikely to have COVID-19. But the co-infection rate is not zero, it's less than 2%. We've also heard from our ID colleagues that the co-infection rate may be higher if the virus that is positive was either rhinovirus or enterovirus. So if you have a high clinical suspicion for COVID and it was rhinovirus or enterovirus, you may still want to pursue with COVID testing. Okay, so next slide, please. So I'm sure some of you are trying to figure out if you even want to or if you should be doing COVID testing in your office. So these are the things that we considered when we were deciding whether or not we should do it or not. The first question was whether or not there is a place in your community where the public can get testing if and when it's necessary. At the time that we started testing 2 weeks ago, we did not feel that there was a place in our community where people were getting tested. So we felt like it was important for our patients in order to provide testing. I think it also came up on the chat box on Friday that there are some places that might have testing available for the public, but it's only available if you have health insurance. So if you don't feel that there is ethical or equitable testing access, that may be another reason why you want to provide testing. The next question I would ask is whether or not you have or are you able to get the necessary testing supplies, which I'll have on the next slide. And then the next thing to do, I think, is to check with your local health department to understand what the local testing capabilities are that maybe you may not be familiar with, and also understanding what labs are available for you to send tests to. So at the current time in Pennsylvania, we have two options. The Department of Health can run tests, and a commercial lab, Quest, can run tests. So the Department of Health in Pennsylvania, they're only running tests on that highest risk category of people. The turnaround time in our Department of Health is about 1 day. The turnaround with Quest is 5 to 7 days. So depending on the urgency of needing to get the results back, that can change your desire to send the test to which lab. If you do send it to the DOH, you do need to call the DOH and unfortunately maybe be on hold with them for some time in order to get their approval for you to send testing to them. So supplies that you need for COVID-19 testing. You will need swabs and viral transport tubes. If you're already doing RVP testing in your clinic, it is the same swabs and viral transport tubes. They're the swabs that, they're the synthetic fiber swabs with the plastic shafts. You do not want to use calcium alginate swabs or swabs with wooden shafts because they contain something or other that may inhibit the PCR testing. You also want to make sure you have the adequate personal protective equipment. So what is optimal and what is recommended is aerosol precautions, and that is the gown, the gloves, the eye protection, the face shield, the N95 mask or a PAPR. As Gavin discussed on the episode is it called an episode on the show on Friday. But we also are all very, very aware of the lack of resources that are available. We also know that there's really no evidence right now that this novel coronavirus is spread in an aerosol fashion and probably is droplet. The other coronaviruses we know are droplet. And so I think there's many places, including our own, that have stated institutionally that it is acceptable to perform testing with a surgical mask in lieu of the N95. So in our institution, we are using standard contact and droplet precautions. So that is the gown, the gloves, the eye protection, the face shield, but a surgical mask and not an N95. So you'll have to adhere to whatever your local guidance is, which is probably going to largely be due to resource allocation. You're going to need hand sanitizer. You're going to need those red biohazard waste bags so you can throw things away. And then you'll need those specimen bags so you can transport things in them. We've been using 2 so that the outer bag can have ice in them because the specimens do need to be kept cool for transport. And then whatever orders or forms that you need to be included with the specimen. Next slide. So this is what the specimen collection looks like. You know, I didn't verbalize it on a prior slide, but I had a picture of the testing being completed outside through a car window. That is the only way that I would recommend doing this testing. I do not think that patients should be brought into the office. I think they should be done outside as recommended by the CDC in the open air. And so we've been doing the testing through the person's car window. And the way you do the testing is you ask them to tilt their head back slightly, as you see in this picture. You pass the nasopharyngeal swab through one of the nostrils until you meet resistance. The swabs will often have a little mark on the handle on the shaft, so you can see how far you're supposed to go. When you meet resistance, that means you've gotten to the back of the nasopharynx. This is very uncomfortable. So people will gag, they will cough, they might even throw up on you. So you want to make sure you stand a little bit to the side if you can and be prepared for that. The difficult thing about this is that you're supposed to have the swab inserted for 30 seconds. You're supposed to rub the swab around. You're supposed to twist the swab around to collect as much cellular material as you can. And then you remove the swab. You put the swab in the viral transport media in the tube. You break off the plastic end of the handle of the shaft, and then you cap it and put it in the specimen bag. So for those of us who are used to collecting RBP, it's pretty much a very similar procedure, except for that you got to keep it in a lot longer than you normally would. Next slide. So then what do you do while you're waiting for results? So if you had high enough suspicion that you tested someone, then they are considered a PUI, or a person under investigation. So I put on here home quarantine, but probably it would have been more appropriate to say home isolation, meaning those folks really should be isolated at home until the results are available, at which time you can then further disposition them. However, I do want to make note that we have seen some reports that the sensitivity of this single nasopharyngeal swab may be as low as 75 to 80%. So that's a problem, right? So what we have decided is that if you have a really high pretest probability for COVID-19 infection, if the test comes back negative, you may want to consider retesting them, or just advising them as if you would if they were COVID positive. And what the CDC has said is that COVID positive people should isolate at home for at least 3 days, 72 hours since fever resolution and symptom improvement of the respiratory symptoms. And this should be at least 7 days since the symptoms first appeared. So keeping that in mind, if you had a low pretest, or I guess if you had low, you wouldn't have tested them, but if you had a lower or moderate pretest probability of COVID-19, maybe you would not need to do this. Next slide. So I think this is my last slide, and it's just kind of hopefully my takeaway points of if you guys are considering doing testing in clinic, these are what I think the first steps are that you need to do. Establishing that staffing plan to be able to manage that increased volume of phone calls so that you can avoid those respiratory illness coughing patients coming into your office. The second thing, I think if you want to decide if you're doing testing, is determining whether other testing facilities are available in your area and whether they meet the local needs. Then confirm whatever the local procedure is for setting tests either to your local health department or to other commercial labs, and confirm whether you have access to the supplies that you need for testing. The other thing, which I didn't mention earlier, is, you know, we're just talking about patients who we deem to be safe for our outpatient testing and evaluation. Certainly there's going to be patients who are sick and need to be evaluated right away, and you need to send them to your local ED. I would call the local ED and see what the process and procedure is. That our ED wants a call ahead of time so that they can be prepared that a patient that you're concerned about is coming, so they can activate proper precautions when they arrive. And then the last thing is to follow the CDC website regularly. This is really hard to do, and there's so many pages on the CDC website, so you might want to task somebody in your group. So someone in our group is the person who's supposed to monitor the CDC website and keep us informed of any updates. So that's the end of what I had, so I'll hand it back over.
Thank you so much, Cynthia. We have a lot of comments and questions in the chat. I think everyone is contributing to providing some answers and also to sharing what they're doing. But I think we have a few questions that haven't been addressed yet. The first one, are you using the same recommendations for isolation for those that are testing positive for COVID-19? I think you were mentioning that about 2 slides ago.
Yeah, so if a patient does test positive, and I'll be frank, we've had a few positive cases in our inpatient setting. We haven't yet had in the outpatient. So you're asking me a hypothetical question that we haven't actually crossed that bridge yet. So, but our plan, if we feel like they are safe to be monitored at home, there is a CDC list of things that you're supposed to tell them to do. So we will have that list handy, and I don't have it right in front of me, but it includes things like, you know, hopefully making sure the person has a separate room that they can be in and be separated from the rest of the family. Pets should be kept away from the person who is sick. They should ideally have masks and gloves, so if they do need to come out of the room, and the people who are helping them should be able to have gloves and masks as well. There needs to be a caregiver. The person needs to have access to food and drink and everything else, so someone does need to be able to be there to help the sick person at home. The person should have a thermometer so they can monitor their temperature and be able to have a way to contact their healthcare provider if their symptoms worsen, if their fever goes higher than they can manage using Tylenol at home, or if they develop symptoms of shortness of breath.
And there's another one. Are there any recommendations for caring for staff if a healthcare worker ends up testing positive?
Yeah, so, you know,
or do you want to do the phone one, or which one?
So this has been a little bit of a moving target. What we have done here is, if we have a staff person who is exposed to a person who has subsequently determined to be COVID positive, it depends on how much protection that provider was wearing, if at all. So the CDC website has this pretty complicated table with if the person was wearing this and wearing this, or not this and not that, and all this kind of stuff. But assuming that we didn't know the person was potentially at risk, and let's say assuming they weren't wearing any protection whatsoever, it also depends on whether or not close contact occurred. So the CDC website suggests that close contact is being within 6 feet of a person for a notable amount of time. If you're clinically evaluating someone, if you're in the same exam room as someone, they consider that to be close contact. However, they don't specify what the time is to qualify as close contact. So I think the thing is, like, if you walked by someone quickly, that should not be considered close contact. But if you were in the same exam room, again, it doesn't say for how much time that would be considered close contact. So for those healthcare providers, what we're following the CDC guidelines, which would suggest that those folks do need to be on quarantine for 14 days to evaluate whether or not they develop symptoms or not. The incubation period is probably average around 5 days. Probably 98% of symptoms will present by the 10th to 12th day. So the 14 days is a very safe time period. And I know that some places in other parts of the country that cannot have their workforce out for that long have shortened that time period, just because that seems to be maybe on the overly cautious side.
Thank you. Are there any other questions for Cynthia? We can certainly come back to them after we go through the case. So why don't we get the case ready? Matthew, are you ready to walk us briefly through the case that you presented on Friday? Because we'd like to continue that conversation.
Yeah, I'm on the line.
Wonderful. We're just getting your slides up.
Do you want me to present the case?
Yes, please do so.
Sure. So my question last week was, should these patients be tested? We had two patients who were a couple living together, and they showed up at our clinic requesting that they be tested for coronavirus. And even though they had mild symptoms and no first-degree exposure contact, we had a question of whether we should test them for coronavirus because of their potential for spreading it among a vulnerable population in our community. So next slide. So part of their medical history was they were denied testing at a nearby hospital system based on that strict testing algorithm. And we had advised them to self-quarantine but they were still very anxious about their symptoms, and they were concerned that they would need to take extended time off of work, and that because they weren't being tested, they wouldn't qualify for the new bill provisions for those that are positive with the virus or being tested for the virus. And for the first patient, he was a male in his 40s. He worked as a delivery driver traveling throughout the city. He woke up with the cough and fatigue the day prior to presentation. And when he called his employer, he found out that his coworker's girlfriend had tested positive for the coronavirus. It's unknown whether his coworker had symptoms. Now we know that his coworker did have symptoms. He ended up getting tested somewhere. The second patient, it was a female in her 30s. She awoke on the day of presentation with fever, cough, and sore throat. She works as a supervisor for a residential living facility, and neither have traveled, but they do live in a large housing project. So with both of them, there was concern for where they work and also where they live about that spread. So I guess it goes back to the question of whether these patients should be tested.
So before we start talking about your questions, there may be people online today who were not here on Friday. Does anybody have any type of clarifying questions that Matthew didn't address that could help make this scenario clearer? And feel free to open up your mic or to put it into the chat.
This is Cynthia. I would be curious about, and I'm sorry if you said this already, but the prevalence of COVID-19 in this particular community.
I think we've had about 40 cases in the county at this point.
And Matthew, another question, where's the closest testing facility and what's the turnaround time for results?
We have 3 primary testing facilities. One testing facility they got turned away from, but because of such high demand. And then the 2 hospital systems that we refer to, you have to be one of their patients to get their testing. So they didn't have great options about how to get testing.
And we have another, and no worries if we've already answered these. Again, we have a mixed group of individuals participating. Any guidance on accuracy of testing relative to the duration of symptoms? Actually, that might be a little bit for Cynthia after the case. So do you want to hang on to that question, Cynthia, and we'll come back to it? Anything else regarding clarity on the case?
And the turnaround time was 4 to 5 days.
Okay, thank you. So with that extra information, oh, we have one more question. Were there pre-existing conditions?
Yeah, no pre-existing health conditions.
So with that extra information, anyone participating, do you have input or suggestions based on Matthew's original question on how to handle this? And if not, I'll see if anyone from Penn State Health, who is part of our panel, I think we have Amy on, I think we have Rebecca, I'm not sure who else, but I know there are a few of our panel members. If you have anything you'd like to contribute in terms of input, recommendations for Matthew's case. So yeah, Rebecca says that the fact that he is a delivery driver makes him a potential vector for this. Erica, can we bring the question back up again? Thank you. So should these be tested is the ultimate question. We could do something a little different. Just out of curiosity, if you have access to your chat, if you feel that these patients should have been tested, can you go ahead and enter yes? And if not, go ahead and enter no. So I'm not going to read through all of these, but we'll collect this because I think this might be some useful information to share, at least to see where everyone is landing with questions of this nature. And I will ask if anyone from the panel wants to add to this before we go back to Cynthia's lecture with more questions on that. So we're seeing a variety of responses to this, and I'm sure that we'll be able to compile these responses and share that out in our follow-up. A lot of different perspectives, and I thank everyone who participated in sharing those responses.
Jackie, can I comment on these responses?
Oh, please do so.
Yeah, so I think that the variety of responses is why this is so confusing. I don't honestly, in my opinion, I don't think there's a right or wrong answer to whether or not these two particular people should or shouldn't be tested. I think there were some people who said yes, some people who say no, and there's other people who said it depends on various other things. And, you know, it's really confusing. And I think it's depending on what your testing ability is, what your resources are, what the prevalence is in your community. So all of those things are in play. One of the things I didn't talk about before is also your patient's ability to self-isolate and ability for them to monitor their own symptoms and report back to you, I think is an important thing too. So I think if you had the capability to test these two folks, that would be fantastic. If you don't have the capability to test these two folks, or if you're holding back your resources because you feel like you need to, it would also be reasonable to have check-in phone calls with these two on a daily basis until it seems like their symptoms are clearly getting better or clearly getting worse, and that might direct what you do from there. So I'm actually not going to answer a firm yes or no, because I think it does really depend. And I think that's why I also said earlier that it's helpful to have, if there's other colleagues in your group, to run these cases by, because this isn't easy. And it depends not only on your clinical judgment, but allocation of your resources.
And if I can just interject a little bit of follow-up to the case, is we just got a call this morning, and now they want to go back to work and they feel fine, but they never got, the test results, and we don't know if they have got testing. So we'll probably end up recommending them be quarantined for 14 days, but it does leave them in limbo where they're not able to go back to work and they never got the testing, so they may not benefit from that bill. And they might have a hard time staying at home too, even though they feel better now.
Any comments to that? I think that that's probably not going to be an unusual case. Does anybody have anything to share with Matthew regarding the follow-up? So there was a question, when does the test turn negative?
So if I understand the question correctly, I think the turnaround time depends on what lab you're using. So if you're using a commercial lab, you will need to understand whatever their turnaround time is. Here in Pennsylvania, we're using Quest as a commercial lab, and the turnaround time, we've been told, is 5 to 7 days. So it's long. If we are able to send tests to our Department of Health, and again, the Department of Health is only testing the most high-risk cases. These two people who were presented would not have gotten approval to be tested through the Department of Health. Those are generally more like a 1-day turnaround time.
So if it's okay, I'm going to start going through the questions in the chat, and Cynthia or anyone else from the panel or participants who wants to provide some responses, please feel free. First of all, we'll go back to that question that you just answered. How long is an infected person testing positive?
I'll just tell you what I know, and then I'm going to defer if other people know better than me. I actually don't really know that answer. I know that the initial guidance for when people could return to work had initially been 2 consecutive negative tests that were spaced at least 24 hours apart. Because of the lack of testing resources, the CDC has lowered that to only needing 1 negative test, and understanding that we're not going to be able to test everyone at all, that there are the algorithm for people who are not able to have a confirmatory negative test is what I had suggested earlier, which was that at least 3 days, 72 hours have passed since recovery of the final resolution of fever, not using any fever-reducing medications, and 3 days have passed since the improvement of the respiratory symptoms, and at least 7 days have passed since the symptoms first appeared. So I know that doesn't really answer the question. So if anyone knows the answer to how long the test stays positive.
So does anyone have any information on that? We'll try to keep that on our radar, and if we do hear any information coming from any of you or elsewhere, We can pass that along. Another question, does anyone know, is the swab through the nose the only testing option, or can it be tested for in the blood?
So the nasopharyngeal swab is what we're primarily recommending at this point, and that is the PCR testing. Um, if I'm going to kind of divert a little bit, and I'll come back to the blood thing. So if if you have a patient where you absolutely cannot get the nasopharyngeal swab, because as you saw in the picture, it does not look pleasant, and you absolutely can't get it done, you can collect an oral pharyngeal swab, but it's not nearly as sensitive. So if you do collect an oral pharyngeal swab, the way you would do that is using the same type of swab. You would, it's the same swab. You would take the swab, you would have to hold the person's tongue down with the tongue depressor, and then you're supposed to swipe the swab back and forth between both tonsils. So you're hitting both tonsils and hitting the very back of the oral pharynx. And all the while doing that, you can't touch the tongue. So I'm not really sure that's better than the nasopharyngeal swab in terms of patient tolerance, but if you absolutely can't get a nasopharyngeal swab, the oral pharyngeal swab is considered to be acceptable, but it's not as sensitive as the nasopharyngeal specimen. So you might see some commercial things out there about blood testing, doing serological testing. That is not currently recommended by the CDC. Like any other serological testing that we do, we know that it takes days before we develop antibodies to whatever we're testing against. And so doing serological testing, if you're trying to do case surveillance, is not going to be a helpful tool. So doing the nasopharyngeal PCR test is what we recommend.
Thank you. So can I go back to the question that kind of came in before the case started? Any guidance on accuracy of testing relative to the duration of symptoms? When's it too early or too late to test?
So, and again, I'll please let people help me out on this. So I understand that the nasopharyngeal PCR test, it can be, it will most likely be positive during that pre-symptomatic phase. However, it's much less likely to have high sensitivity during that time. So you're much more likely to have a higher specificity, a higher sensitivity once the person is symptomatic. However, we do know from that, is it called the Diamond Princess, the big cruise ship experience, where they tested everyone, whether they had symptoms or not. And there was, I don't remember the numbers, but there were quite a few people who tested positive in the asymptomatic phase. So we do think that the test will still be positive in the asymptomatic phase, but that doesn't mean it'll always be positive in the asymptomatic phase.
Thank you. Anyone have anything to add to that? I hate to keep putting Cynthia on the spot with this. And again, I'll teach, I'll learn. So it's not just us, Penn State Health. Anyone that has anything to add to these questions, please do so. So we do have another question. This one is actually from Matthew, who presented the case. What's the difference between, and if this was answered, I apologize. What's the difference between the OP and NP swab? LabCorp told them that they were both options.
Yeah, so it's the same actual swab that you use, that same swab with the plastic handle. So it's the same one. Yeah, right now the guidance is just a single nasopharyngeal swab is adequate, but you know, if you can't get it, you can do that get an oral pharyngeal specimen. Some of us last week were doing both because we were told to collect both, but that has been streamlined to just needing the one nasopharyngeal swab. So the test with the 45-minute turnover, I think it's really important to see if that is PCR testing or if that is serologic testing. So the serologic testing is almost immediate, and that's the one I think we want to stay away from. The PCR testing takes several hours to run, as far as I understand. So if the Cleveland Clinic has a 45-minute turnover, if they found a way to do the PCR testing that quickly, that is awesome, but I would clarify whether or not it is PCR testing or not.
Does anyone else have any experience with what's going on there? Okay, so I'll ask, are there any final questions? I know we're a little bit early, but I'm sure everyone could deal with 10 extra minutes in their day. Any final questions or comments? Okay, there is a question from Melissa.
Could it be antigen-based POC testing like POC? Yeah, I don't know. I would be very curious to know what that is. I am not familiar with it.
Is anyone else familiar with that? Again, something to keep on our radar, not just Penn State Health, but anyone. If anyone hears anything or reads anything regarding these few questions that are kind of out there, please feel free to share them with our ECHO team, and then we could get that information out as well. I'll wrap up then if there are no other questions. Just real briefly, remember you are able to collect CME credits for participating. Thank you so much for participating. You will receive a survey right after the session with a link to a case form. Please consider submitting a case, whether it's a general question. And thank you again, Matthew, for being on the spot twice. And we do have another session at 4 o'clock for hospitalist sections. But before I turn it off, I see one last question. Could there be error during testing, particularly with making a mistake that could make a negative person a positive?
So I don't think we know, at least I don't know a whole lot about false positives yet, but we do know from kind of our general epidemiological knowledge that if your population prevalence of disease is low, no matter how good your sensitivity and specificity of a test is, that you are going to have false positives. So even more reason why you might have hold back testing if you still have no prevalence recorded in your community.